Um, so, the topic today, first thing, and also tomorrow, is about stopping clinical trials early. And if you've ever done a clinical trial, you obviously want to get it done. Excuse me. We've started now. Thank you. If you've ever done a clinical trial as an investigator, you obviously want to get it done as quickly as possible, right? You want to use smallest possible number of patients, get your results, get published, become famous, and so on. But there are quite a lot of issues about the decision to stop. And so this morning we're going to talk in particular about stopping early when it seems as though the treatment might be beneficial with a substantial treatment effect. So there seems to be no point in continuing because you've already got the result, right, from the early data. And then tomorrow we'll look at the opposite situation where the early data seem to be suggesting that the treatment effect is very small or perhaps nothing. So you want to stop for that reason, and we call that futility. There's no point in continuing to the full sample size. I was just talking with a couple here, and has anybody actually been in this situation where you've done an early analysis or an interim analysis in a trial and you think about stopping? Okay, I'll maybe come back to you. Anybody else? So you told me, right. Okay, so we'll maybe get your experiences about this because it is a very practical issue. And I'll be introducing a number of practical examples from the literature. And we have to talk about that as well, the papers that I mentioned in the booklet that we'll be discussing later. So we'll look at some practical examples, but we'll also look at some of the theoretical issues behind it as well. So just by way of introduction of me, Dr. Jayaseelan said a few things yesterday, but as it says here, I'm from McMaster University in Hamilton, Ontario, and perhaps if we have time, maybe tomorrow I can show you a few pictures from home just to give you an idea of where I live. But more to the point here, this is now my department name. It's rather long, Health Research Methods, Evidence and Impact, and we were previously Clinical Epidemiology and Biostatistics, which is also quite long, but not as long as the name that we have now. And so the new version, which is about a year old now, was the legacy of our department chairman. That was one of the big things he wanted to do as chairman, was change the name, and he did it. He's actually gone now. He's not the chairman anymore. But I don't actually like the new name, but there you go. Anyway, So here's our outline. We'll start first with some of the general reasons for stopping trials early and what you might consider if you're thinking about doing an interim analysis. Then we're going to look at some literature, some surveys that have been done on trials that have actually stopped for benefit in particular in this set. And one of my particular research areas of interest is to see what that effect has on the treatment effect that you estimate. When you stop early, you may actually introduce some bias in the estimated treatment effect. And today, this morning, we'll also look a little more quickly at the idea of stopping for harm. So the effect seems to be going in the wrong direction. That the new treatment seems to be worse than your current treatment or standard treatment or even placebo, and you might want to stop for that reason. And then at the very end this morning we'll talk about the examples and the exercises based on those examples that I mentioned yesterday. So we'll start off with some of the general reasons for stopping early. So here are some of them. We're going to be talking this morning mostly about stopping for benefit. That means that the early data are looking positive, that the new treatment seems to be better. I mentioned harm just now. Futility is another reason. And futility actually has two subgroups to it. One is statistical futility, meaning that the early data seem to be showing no effect or a very small treatment effect. But another common reason that is also called futility is that you have slow recruitment of patients to the trials. And in my experience, with all due respect, doctors are not very good at knowing how many patients they have. And when you start trials, they'll say, oh yeah, we've got loads of patients, we can do this trial in no time at all. But then when it comes right down to it, it turns out that they don't have as many as they really think. And the reason is, of course, they're very busy. And so they think they've got lots and lots of patients, but some of them are the same people coming back again, right, for repeated visits. So they're not thinking in ways that we would like in terms of designing the trial. So sometimes it may turn out that you simply do not have enough patients to get the job done with your available resources. So that's a common reason for stopping. Another one is funding, which obviously is required to do these trials. They can be quite expensive, so you may not have the budget available to take it to its completion. And we hope this never happens, but sometimes it turns out that the data that's being gathered is just of very poor quality, so it's obvious that even if we carry on to the end, we're really not going to be able to get a reliable answer because of that. So, okay. There is actually a little bit of literature on this area, and I've been involved with my group in doing some surveys of trials with this in mind. So one particular study that we did was to look generally at the characteristics of trials that were being published. And so this was quite a large sample of trials, and the 562, and this was done for a lot of different reasons, but the reason that I'll focus on here is looking at the ones that actually stopped early. And you can see that it's not at all uncommon to stop early. About 14% of trials stopped early and didn't go to completion. Most of them, or at least half, were stopped within that group for efficacy, so that's benefit, if you like. It's looking like the treatment is very, very good and we want to stop early and get the result out. About a quarter stopped for reasons of harm, 9% for futility, and 12% in the other or poor recruitment or accrual reasons. So that's the general situation. Some of the other reasons for stopping early, quite independent of what the interim data might say in your study, from the ethical point of view, you want to have as few patients as possible on the inferior treatment, because it's obviously unethical to keep going if you can see that one of the treatments is not so good. Another reason for stopping is that there may be other investigators who are looking at the similar or the same question, so you may have external evidence that comes in. You, as an investigator, you hope this doesn't happen, that somebody else publishes a result from their trial before you did, but that may be a very good reason to stop, that it really there's a very convincing trial or other evidence coming in, which means that your trial just shouldn't be continued. Sometimes people find it's just too much for all sorts of reasons. They're spending too much time on it. The energy or the resources that are required are just too much to justify given the result that you may get at the end. Another reason for trying to stop early, regardless of what the data says, is that you will have fewer patients in total and a faster result. So we sort of speed up the scientific process as far as possible. And I was mentioning just now, just before we started, I work in a lot of trials to do with cancer screening. And there, by definition, if it was screening for cancer, most people don't have cancer. So you have a relatively small number of people who do, and they get found early, but you have to follow them up for quite a long time to look at outcomes and decide if it was actually worth it to do any screening. And the technology is changing all the time. The imaging, for example, is changing all the time. So by the time you've waited 3, 5 years, even 10 years, to follow up the people in your randomized trial, the technology has all changed. So you've got a great answer, but it's for technology that's really out of date. So that's a problem, and you do want to get the answer out as quickly as possible, even though it may not be the ideal one with a full sample size. Another reason to stop is that, you know, we've only got 24 hours in the day, and we may want to do other things that are more important. So it's a matter of research priorities. Yeah, for the people who are just coming in, just to say, we decided to start at 9, and tomorrow we will start at 9, okay? It's all right, just so people know. I know it was in the program for 9:30, but it will be 9 o'clock. And then the last reason for possibly stopping is that if you have a suspicion of benefit, or more particularly suspicion of harm, and you continue the study, you may actually be opening yourself to some legal exposure. Maybe that doesn't happen so much in India, but in North America this is a big concern. And I'll show you an example later on of harm where that was a major issue. It did actually continue, but when, in hindsight, looking back, it was thought that maybe they should stop the trial much earlier. So a lot of different reasons for stopping there. Now let me show you a particular example. It's coming back, is it? All right, here we are. So this was a trial where it was looking at, this was a cancer therapy trial, and it was looking at 4 versus 5 courses of, I think it was chemotherapy. And you can see that at the first analysis that was done, there's old data, but it doesn't matter, the principle's the same. In 1997, in the longer treatment group, we had 7 deaths out of 102, and in the other group we have 15 out of 100. So the death rate in the first group is quite a bit lower than the second group, and this is just to assess the significance of that difference. It's done by the difference of the observed and expected number of deaths, expected based on the null hypothesis, of course. And so here's the first result. We had there were 7 actually observed, but that's 4.6 less than you would have expected. The average obviously would have been somewhere close to the average of 7 and 15. The denominators are not quite the same. If you look at that in terms of the relative odds, so quite an impressive effect, 57% odds reduction, and the p-value, the two-sided test, of 0.05, so borderline statistical significance, okay, and somewhat wide confidence intervals. And you notice here that the upper confidence limit on the odds ratio here, actually for the hazard ratio, is just on the boundary of hazard ratio of 1, and that's why the p-value is pretty well on the boundary as well, 0.05. The two have to be consistent, of course. So, okay, at that point the trial continued, and the next year, 1998, we have a new analysis, and this time we've got quite a lot more patients, and this with roughly equal groups. We've got 23 deaths in the first group, 42 in the second group. So that turns out to be a quite similar odds reduction, 53% as opposed to 57%. And now the confidence interval has tightened up. It's got narrower because we've got more data. And the p-value on that is 0.003. So by conventional levels, that's a highly significant statistical result. So the question to you at this point, if you're on the monitoring committee, would you stop that trial? Yes. Yes, a lot of yeses. Okay. And I think a lot of people would sympathize with that. Okay, what actually turned out, if you keep going, they didn't stop, but they obviously thought this was a very encouraging result. And I deliberately didn't put this in your slides because I didn't want to bias you. They actually did a new analysis in the same year, and even more results coming through now, 41 against 66. The odds ratio is still quite similar, a little less than before, 45% risk reduction, and even more significant result. And you guys said mostly that you would stop anyway. If you had stopped in the first 1998 analysis, you'd certainly have stopped now by the same logic. Continuing on, and I'll spoil you now by showing you the full picture. The trial actually decided to continue and went all the way to 2002, so that's another 4 years of data accumulation. And the final result here is 9% negative odds reduction, so it's actually leaning slightly the other way in terms of the short courses, so 4-course treatment, and the statistical significance has gradually disappeared. So essentially the final result of that study was of no difference. Now, I haven't gone into the detailed reasons why they decided to continue at that point, but clearly if they had stopped, they would have got a very misleading result. Now these tests and estimates here, of course, are highly correlated with one another because each one contains the data that had come before, and you're just adding the new information in as well. And I don't know the reason for this drift, but it could be that just by chance in the early stage, when you've got a very small number of deaths, just by chance, statistical variation, it happened to lean very much in favor of one treatment, and then that effect just gradually wore off. The law of large averages, if you want to call it that, gradually made the effect disappear. So this is a case where if you had decided early on to stop in 1998 and publish your result with very encouraging evidence for the 5-course treatment, that you would have actually got totally the wrong answer. And who knows, we could then have been looking at a time period when that particular treatment, the 5-course treatment, would have continued, it would have gone into general practice, and we would have actually been doing worse for new patients than would otherwise have been the case. So that's the dilemma that we face generally. Should we stop on the basis of this early data with less certainty about the result, or should we continue and try and get the full picture? Yes, a question from the back. Yeah. I don't know, somebody's got the microphone for you? Yeah, okay. Yes.
That is extremely discouraging because we've been taught that if you find a statistically significant difference, you repeat the test 100 times and 95 times, and that's what we've been teaching and learning and saying. So it is quite discouraging, especially because the kind of research we are involved with are small or mostly non-funded small research. And when we've found, we've always thought that we found something very important. But it's discouraging to know that if you have a larger sample size...
Well, okay. To be fair, this is an extreme example, deliberately chosen. And of course, there are many other situations where if you had stopped in 1998, it would have been the right decision and you would have saved all those other patients being on the inferior treatment. But it's a statistical decision, and statistical processes are never error-free. There's always that possibility of making a mistake, and this is one particular example of that. Yeah.
Sir, what means this is the final chart that you will look at, or probably you will look at Kaplan-Meier graphs and see the censoring has been done, what kind of patient has been dropped out of the study or like that. So what all kind of factors do you take into account while coming to this result, whether to go or no go like that?
Okay, well I can't go into the full details of this study, but we have to presume that the analysis that you're seeing here took account of all of those things. And you would obviously want to try and find out what the reason was for this drift in the estimated odds ratio, or hazard ratio. So it could be that there was some bias going on, particularly in the early stages of trials. You sometimes find that people aren't totally up to speed on the trial procedures, so it's possible that some bias could have come into play. You mentioned losses to follow up and so on. So yes, you'd certainly need to look at all those issues to try and explain it. And clearly the monitoring committee, the data monitoring committee, should not just be looking at the the estimate in isolation. You want to be looking at everything else, including the scientific and the political context of stopping and the negative aspects of stopping, if there are any. Yeah. Yes, okay. You need the microphone, I think, because people will not be able to hear you. Yeah.
If you're stopping the trial earlier, will we reach the power to say that it is significant?
Sorry, can you repeat that?
Yeah. If we are stopping the trial in 2 years' time, we wouldn't reach that sample size to say it is significant.
Oh, but it is statistically significant. It already is statistically significant here, even though we didn't reach the target sample size.
Will it have the same power to say that?
The power is not the power is not an issue. This is the same thing as yesterday, right? Once you've done the study, you're not thinking about the power anymore. You've got the result. So in 1998, this is the result that you have with its significance level. It is statistically significant because the early results were very encouraging. The power is not the question anymore. But that creates the conflict, right? And as I said, the p-value is not the greatest measure of evidence, but another factor here is the very large effect size, right? The two obviously go together, but a 50% reduction in the hazard ratio, that's a pretty big effect, right? That's why these investigators would be strongly motivated to publish that result right away. And unfortunately, in many of these situations, it's not really possible to publish interim results because that would affect the conduct of the later stages of the trial. If people think, if you published in 98 favoring the 5-course treatment, then people would be very reluctant to go into a trial where, you may possibly get the treatment that looks worse at that moment, right? Yes, okay, one more question, then we need to move on. Yeah.
If we say that for cohort studies, which is primarily looking at safety issues, post-marketing surveillance, so maybe a long-term study where we want to pick up the adverse events, rarer adverse events.
Right.
Maybe one should be more liberal in that scenario.
Yes.
Vis-a-vis an efficacy study. If
Yeah.
I derive
Yes.
this direction
Yes.
from that.
Yes.
So would you like to encourage that we should be more liberal for post-marketing drug safety studies and not stop the trial early?
Well, okay, I've only shown you part of the result of the study, and of course you would want to look at side effects. And there's two aspects of stopping for what we call harm. One is that the treatment effect is going in the wrong direction, the treatment effect itself. And the other type of harm, of course, is side effects, serious side effects. So you'd need to look at that. And I will be speaking about that in a little while. But generally speaking, if you're looking at standard therapy versus a new therapy, you typically err on the side of caution. That if the new therapy is looking as though it's harmful, you would be more inclined to stop for that reason than if it was going the other way. Yeah. Okay, all good comments, thank you very much. Let's just move on now to some of the other issues. One of the major things about this and looking at the p-values is that we've done a bunch of significance tests along the way. And so we've done repeated testing for significance over time. And what implications does that have? Well, this is very similar to what we were talking about yesterday with subgroups, for example, that if you do enough significance tests, if you slice and dice the data in different ways, then eventually something will be statistically significant almost for sure. So this is a problem. The more you look, the more you're likely to find to be statistically significant. And corollary of that is that the rate of incorrectly rejecting the null hypothesis, that is where there's no treatment effect, but you declare something important going on, the rate of doing that is much larger than we normally say. So if you're operating at the 5% significance level, for example, the actual chance of finding something significant at the 5% level is going to be much higher than 5%. And of course the other general problem, as we saw just now, in the example is that these trends may emerge and disappear, especially early on in the trial when you have much less data, and so the variability is much greater as well. Just to look at some numbers on that, you may have seen this type of argument before, that if you have a number of significance tests done at the 5%, and if we for the moment assume they're independent, so completely different analyses, then you see that as you go from one test only with a 5% error rate, if the null hypothesis is true, as you move up the number of tests, the error rate increases quite rapidly. So if you do a lot of different tests, say 10, it's a 40% chance that you're going to have a false positive result. So you definitely need to be aware of that problem. Now, in repeated tests of the same trial, it's not quite as bad as this because the tests are not independent of one another for the reason that I said just now. I won't go back. We're looking at incremental testing of the combined data over time. So the test that I do today will include the data that I did in the last analysis 3 months ago, right? So it's not completely independent. And that has the result, if we look at the corresponding rates of false positives, you see it's not quite so bad. And you have to make some additional assumptions in this, but if we assume that we do equally spaced analyses over the course of a trial, even if you do 10 tests, where it was 40% before, it's only 19% now, but still quite a bit larger than what you would think of as the actual level being 5%. You'd like to think it was 5%, but it's not. It's still much higher. So one thing you can do to avoid that particular problem is to change the level of significance that you're working at. And to do that, for example, if you are going to do one test, well, no problem, we just operate at 5%. We set the alpha level at 5%. But if you do two, you have to actually change it, it turns out, in the context of a trial, to 2.9%. And notice this is not quite the same as the Bonferroni correction. People who've done this before will know about Bonferroni, where you just divide by the number of tests. So it's not exactly the same as 2.5 as you would have with that, but it's slightly higher than that. And here's how it goes. So if you're planning to do 10 analyses along the way, like we saw in that cancer trial, you'd have to require that the significance is at 1% or 1.1% on each occasion. Okay. Now it turned out in that particular example it was still below that, right? The p-value was less than 0.01. So you would still declare significance even making that correction for multiple testing. Yes?
What kind of correction is this?
This is a boundary actually for multiple testing in the context of a trial. Now I'll actually tell you how this arose. This is actually the one where you have constant alpha level at each of the tests.
How we compute this?
Okay, can I come back to your question, how you actually came to it? Because this is not the only possible thing that you might want to do, and there are alternative ways to control this problem of the type 1 error rate, or the false positive error rate. So, to answer your question, how do we approach this problem of repeated significance testing? And so there's now quite a large literature on these methods, statistical methods for monitoring, and most of them consist of adjusting the critical value in each of your analyses so that the overall significance level is at the required level. So you set out your analysis plan, you say, well, I'm going to do analyses at 3, 6, and 9 months, and then the last one at a year after starting the trial. And I'll set it up so that my overall type 1 error rate or false positive rate is 5%. I choose those stopping times or analysis times, and I'll define my critical values. This is instead of 5%, I'll replace them with something else so that that property is still okay. And one of the major approaches using that idea is the so-called group sequential methods, and we're going to have actually quite a bit more on adaptive trials. This is one particular example of a group sequential method where you deal with this idea of repeated testing at the interim analyses. You set up a boundary or a threshold for this monitoring process, and this means that at each analysis you're going to have some criterion for rejecting the null hypothesis at each one. And some of the major methods that have been proposed go by the names of the authors. Stuart Pocock is an English statistician, O'Brien and Fleming are American, and Hay, Bittle and Peto also British. So, and what do they do? Well, let's have a look. So the general idea is that you're going to have, over time, you're going to have an estimate of the treatment effect, which if you go up on the graph, it's going to be showing you benefit, and if you go down, you're going to be showing harm. So the sort of neutral point here will be no treatment effect on the blue line, and let's imagine that the true treatment effect is there at the yellow line. We don't know that, of course, at the beginning, but let's imagine that that's what happens. And we may define a stopping criterion, so we have a threshold that's higher, quite a bit higher possibly, so that if we cross that threshold at some point in an interim analysis, we will stop the trial. We'll come up with some rule to do that. Now, in the data, this is what it might actually look like. We start off with a lot of variability as we go along, but hopefully, if everything's okay with the trial and we've avoided bias, we've got everybody randomized appropriately and so on, we gradually will converge to the right answer. If you get a large enough sample, you'll gradually converge to the true effect, and you'll get rid of the statistical variation in outcomes for individuals without any bias. So in this particular example, it turns out that we did actually cross the threshold there, and we would stop the trial. We would stop the trial at this point if that was the decision-making process. So we would stop the trial at this point if we did an interim analysis. And what does that mean in terms of the estimated effect? Well, we would estimate it's up here somewhere instead of down here on the yellow line. So this is sometimes referred to as a random high excursion because of lots of variability in the early data. And it means this random high means you're going to be overestimating the treatment effect, going to be overestimating the benefit. So this is one of the, in my view, one of the key issues about stopping early, that you may misestimate the actual level of benefit. Okay? And of course, if the early data was not crossing that line, then you just carry on and you get the correct answer at the final sample size.
So that stopping criterion should be both sides, not only the upper side.
Oh yes, that's right. You could have a criterion. Yes, we're talking now about stopping for benefit, right? This morning we're talking about stopping for benefit. So we're just, for simplicity, if you like, we're talking about stopping on that side, but you could also have a similar criterion about stopping for harm. Yes, that's right. And we have an example of that later on. Yeah. Okay, so here's what some of these boundaries actually look like. And just as a particular example, what we're seeing here is the situation where you're planning to do 2 interim analyses before you get to the final analysis. So that's 3 analyses overall during the trial. And as you said just now, this could actually be one-sided testing or two-sided testing. Most often you do two-sided testing. And you can see that the thresholds for stopping depend on which particular set of rules you're going to adopt. Now, usually with two-sided testing, for example, you remember you have to be outside plus or minus 2 standard errors, or 1.96, there's that magic number from the normal distribution, right? So if your test statistic is more than 1.96, meaning that you're higher than that number of standard errors, above above 0, that would be a statistically significant result at the 5% level. So the scale on this is actually based on the Z statistics. And you can see that, let's have a look at this O'Brien-Fleming rule. First of all, the red line. And I'm sorry that I think the colors don't really show up on your black and white printing in the book, so you may just want to... Actually, you do have a plotting symbol for those, so you can tell. But for some of them, you might actually need to note which is which. So with the O'Brien-Fleming rule, what happens is, if at the first analysis, you would require to stop an effect that had a Z value, test statistic, bigger than about 3.5. So much bigger than the 1.96. So it's a very conservative rule. It takes a really significant result. I don't know what the p-value for that is, but it's going to be 0.000 something. Very small p-value at that point. But as you go through the study, that particular set of controls for monitoring goes down, and you end up with the last one being just above 2. So a little bigger than 1.96. The Pocock rule is the blue line, and that's the one where you keep the significance level the same at each constant across each of the interim and the final analyses. So that's a simple one. But of course, this means at the first analysis, you have a bigger chance of stopping with Pocock, right? So which of these rules you adopt depends on what kind of risk you're prepared to take at the beginning, right? So if you say, well, it really has to be a spectacular result before I'm prepared to stop, then you would go with O'Brien-Fleming, because that's the most conservative one. But the price that you pay is that at the end, at the very end, it's a little subtle, but you can see that that means then that your required value is a little lower. Actually, it's not a price, it's a benefit. It's a little lower than if you'd used Pocock at the beginning. So if you take a bigger risk at the beginning, there's a penalty to pay at the end, because the final result has to be a little more significant than otherwise. And that trend is a little more obvious in the one-sided testing rule. You'll notice that with Pocock, it's just about 2 for the test statistic, and it stays at 2, of course, for the final analysis by definition, but the other ones you would need a slightly less significant effect. And remember that this is on the normal distribution, so there's a huge difference in the p-values between a Z value of 1 and 2 and then 3. Those are very extreme values. 3 standard deviations is really quite a long way out in the tail. And if you're interested to see I'm sorry for the quality of this plot, but it's about the best one that I could get of this particular case. This is showing you much the same thing, the boundaries, when you have 5 tests along the way. And you can see then that there's quite a lot more variation in the required effect size. So this is the standardized effect size. It's the Z value that we had before. So the differences between these methods start opening up a little bit more. And so, as it says here, if you do these interim analyses and the Z statistic is somewhere in this region, not particularly significant, then you carry on and you test it finally, and it may not be significant at the very end, in which case you accept the null hypothesis. Otherwise, you would declare significance. And I think the next slide actually shows you, yes, so this is what the actual critical values are for the test statistic. So at the very bottom then, that should say non-sequential, you would use 1.96 as your test statistic value. This is two-sided testing, of course, and the p-value that corresponds to that is 0.05, the normal situation. And this is the required Z value for a design with 4 interim analyses and then a final analysis. And in this context, people sometimes talk about the information fraction. How much of the final amount of information do you have at each stage? Basically, that is talking about the fraction of the sample size that you've accumulated in this case. So if you're using the Pocock rule, you have a constant Z value required, 2.41. The p-value for that is 0.015. Okay, so we've seen similar to that before. So instead of testing at 5% each time, you do at this level, and then that gives you an overall 5% type 1 error rate. Okay? Just in contrast, the O'Brien-Fleming rule with 5 is very, very conservative, so you have to have a p-value that's 0.00001, less than that. So it really has to be a dramatic effect for you to stop at the first interim analysis when you've only got 20% of the sample size. And then gradually that p-value, that required p-value gets a little bit bigger, 0.001, 0.008, 0.02, and then the last one, 0.04 instead of 0.05. So it has to be slightly more significant than before with the normal test. So it's a little price that you have to pay, but not very much, because you didn't take much of a risk at the beginning. Whereas with Pocock, well, you did some, tests with a bit of a risk there, and so your final result has to be a lot more significant at the 1.5 significance level compared to the 5% that you would otherwise have used. So it's a question here, choosing between these rules. How urgent is the question? What sort of risk do you want to take at the beginning? And what penalty are you prepared to pay for that in the final analysis if you use a fairly liberal test at the beginning, like Pocock?
0.2, 0.4 on top.
Sorry?
0.2 and 0.4 on top.
Yes, that's the information fraction. It's essentially, at this point in the first one, you have 20% of the observations in. 20% of the patients have come in as a fraction of the planned total. So the first interim analysis is at 20% of the sample size, 40, 60, and then 80, and then 100%. Okay?
Patients analyzed.
Yes, with outcomes observed. Yes, so the first one would be when you're planning, let's say, 100 patients to be in the trial. At the first interim analysis, you have 20% or 20 with actual outcomes observed. All right, another question?
Is there some recommendation for the interim analysis?
What do you mean recommendations?
Do you recommend interim analysis after a certain number of women are?
Well, that's up to you as an investigator. As I said, it depends on the urgency that you have for this particular question. And as I mentioned before, it's not just for benefit that we'd be looking. You might be concerned about side effects. So you might say, well, I really need to do an early analysis to worry about that particular issue, about the side effects. You might, for instance, have come up with a plan where you do one at quite early at 20%, but then do nothing else until the end. So you can adjust these p-values for any particular plan. This is just the simpler case. Yes, you had a question.
Yeah, sir, can't we use, like, for first and second interim analysis, I will use OBF, and for last 3, I can use Pocock?
That's an interesting question. Can you change the rules as you go along? The quick answer to that is not really, because if you do that, then you don't have this property of 5% overall, and goodness knows what you do have. Right, so that's cheating. It sounds like a great idea, but there are actually some more flexible things which I'll tell you about in a moment, but these are kind of the simple options where you set everything up in advance. Okay?
So for the Hay-Bittel and Peto, it's showing 3 everywhere. How come? Because when we saw the graph, it looked different.
Yeah, this is the Hay-Bittel-Peto rule. That's one where you have pretty demanding p-values. There has to be a pretty big effect for all of the interim analyses, but then you drop the value. This actually isn't exactly 1.96, it's a little bit higher than that, but very close. So that strategy says, okay, I'd like to have a little look, but it really still has to be a big effect at any of the interim analyses, and then the final analysis.
And I think the one for harms is more strict than this, is it?
Okay, but we're talking about benefit here. I'm going to come to harms later. Yeah. Okay. With harms, you obviously have to be a little more conservative, or which way is it? You're more concerned, so you may accept more risk of stopping early if you're seeing evidence of harm. Yeah. Another question back there, and then you. Yes. I'm sorry, we can't really hear you from here. So can you take the microphone, please?
So I understand that my perception is that the boundaries which we discussed, habital Twitter or brain flaving, are based on this treatment effect graph where you see a random high first and then it goes decreased. But is this graph is a universal truth, or is there any chance that this may be a chaotic thing and whatever we are considering is a total false thing?
Is there any chance that
That means this graph is not the way it's like, so you may get random high later on also.
Oh, you may get, oh sure, yeah. I mean, it could go across and stay up there, or it might go up and come back down again and go over the threshold. So it depends whether you have an interim analysis planned at the time when you're over the boundary or not. But what you do hope is that eventually you will come to the right answer. So what this is really suggesting is that the variation will gradually go away because of increasing numbers, and you should converge to the right answer. Now, if you don't converge to the right answer, then you've got a problem because it's telling you that there's some bias going on. Right? If you, in the end, with a lot of information, given the wrong answer, that can only be because of bias.
Okay. So, in the sense, so suppose a trial is going on and you're, you're looking, I don't know how this process is done. So, like for stopping for futility as well as stopping for benefit, we look at concurrently at the same time. And
yes, you could do. Yeah.
Okay.
Yeah.
And so, in that sense, whenever it comes like the graph shows that it's coming to a true treatment effect, then we will stop probably like that.
Okay, just to repeat, here just for simplicity, keep life easy, we're only talking about stopping for benefit, but that's not the only thing that you may want to do. You may want to also be monitoring stopping for futility, in which case you'd have to have another part of this diagram where if it happened to drop low and cross the threshold, you would stop for that reason. Okay? But I'm just trying to keep things simple here.
Okay. Thank you.
Okay. You certainly would want to do more than just this one thing. Yeah. Okay. Last question, then we'll move on.
Just wanted to confirm, like, do we need to commit that we will do interim analysis at the design stage itself, or I could proceed and just decide that I go for interim analysis somewhere halfway? That is one, sir. Mm-hmm. And secondly, at the first interim analysis, I have the choice of choosing any of these rules, or that is also to be specified before I plan my study?
Okay, those are excellent questions. Let me just go to this one. Okay, so the first question you had was, do I need to do it this way and set it up in advance? The answer to that is actually no. You can be flexible, and I'm going to talk about that in a moment. But these are kind of the simple approaches where you do, in fact, plan in advance. And of course, this could be beyond statistical issues. It could be just administrative reasons, okay, that we are going to tell. There's a lot of work involved in getting all the data together, you know, from the different sites and getting all the data sets cleaned up, ready for the analysis. So for administrative reasons, you might say, well, look, this is a huge amount of work, but we can do it once every 6 months. So in a 2-year study, we'll do 3 analyses, 6 months a year and 18 months, okay? So that would be the simple approach that you would take, setting it all up in that way. But you can indeed be flexible, and we're going to talk about that in a moment. And the second question, just remind me.
The first choice could be any of these rules?
Oh, yes, yes. If you're going with the simple approach, where you define everything in advance, then you must commit to one of these rules. And there are other ones, of course, but this is the most common situation that we have. So you do have to commit to these, and you can't change trains while they're still moving. You can't jump from one line to the other. You do have to commit, because otherwise you're cheating, and you won't have the 5% control that you do with taking the whole package. Okay, so let's move on. These are excellent discussion points. Oh yes, sorry. I need to go back. So the limitation that people have pointed out with these group sequential methods, such as I've shown you, is that this problem that you do have to define it in advance, which may actually be a good thing because of the administration load that you place on the investigators. And another limitation is that most of the simple rules say that you have to have equal numbers of participants, that's patients, or events between each analysis, in other words, equally spaced. There are, in fact, ways to calculate the p-values, the thresholds required if you go away from that. So you might decide to, say, have a couple of analyses early on and then a longer period, so there would be different numbers of patients, different spacing of these analyses. It is possible to calculate these boundaries, but of course it gets a little more complicated to do that. So an alternative to that is the so-called flexible sequential methods. And in this approach, what happens is, you remember the alpha is the type 1 error rate, and they refer to alpha spending. So you have a budget. I give you 5% at the beginning, and you can spend it in as many ways as you choose. You may decide to keep it in your pocket until the end, and that means you never do an interim analysis. I'm not spending anything. I'm a what they call it, skinflint, right? I don't like spending my type 1 error rate. And in fact, that's a very reasonable position if you want to keep life simple. You're not too worried about side effects and so on. You just say, well, we'll do the study and come to the end, right? We'll do it. Spend the 5% then. But if you are worried about some of these issues, you think there might be good case for early benefit, or you're worried about side effects, for example, if you're testing for harm, then you dip into your pocket and you take out some amount. Let's say, well, I think it's a small chance, but let's have a look. I'll give you 0.0, what would we say, 0.001. I'll give you 0.1% of my 5%. Okay, so you can spend that now. And then, based on that, once you see that analysis at that point, you can decide whether you want to do any more or not. You might. So let's say I spend 1% at the first look, and everything looks fine, no problems, there's no evidence of side effects and so on. I want to get to the end, I'll just keep the other 4% in my pocket. Okay. So there are these approaches where you can work out what the threshold has to be at each of these analyses if you decide to do them, such that, again, the overall type 1 error rate is maintained. And there's a very nice website which is on the slide there. These methods were largely developed by these people, Lan and Demetz, and that's hence known as the Lan and Demetz method. They became famous by developing these. And there's a website there at the University of Wisconsin that you can look at, where you can actually go in and see what your plan would be for alpha spending, depending on what you're thinking about in terms of when the interim analysis should be done. Yes?
One aspect is looking at it in statistical significance and then comparing. The other thing is clinical significance. Mm-hmm. So it might not be appropriate to do a statistical significance and prove, like I would like to tell with one example of our trial.
Okay, then if you're going to make a detailed comment, you need a microphone because I think people can't hear you. Could you just summarize what you said? Got it? Yeah.
So this is regarding clinical significance and statistical significance. So we had a clinical trial with, it was a 5-arm trial. One was a control and 4 was a test regimen. Basically, we were trying to see if shorter regimens for TB work. So this is based on TB recurrence rate is the primary outcome of that study. Mm-hmm. So we found that it was regimens of varying duration like 3 and 4 months. We set up the interim analysis at two point in time when 30% of the enrolled have reached the outcome and then 60%. But what happened was in a 3-month regimen, after we enrolled 100 participants, there were 20 participants who had TB recurrences within 3 to 6 months of stopping treatment. So that was nearly a 20%. And we had assumed a 5% and equivalence design between the control and the test regimen. So the 20% recurrence occurred within 1.5 years of our trial initiation itself. So what was thought was when the DSMB was reviewing the project, and they said as physicians or treating clinicians, if 20% of them are going to have recurrence with the regimen in the controlled RCT setting, then if we are going to take this regimen to the field, then it would be much larger. So instead of doing a typical statistical significance itself, they said this regimen, you're not going to enroll patients further to this regimen. You might continue with the next regimen.
Well, okay, I think the example you described is stopping for harm, right?
So every time, what I'm trying to say is you need not look at statistical significance also. I think
wait a minute. Okay, so you're finding that things aren't going well with one of your groups, but in the back of your mind there, you have some threshold that you're thinking about that would say, well, this is unacceptable, an unacceptable thing, right? But fine, so that could be part of your stopping rule, that if that's observed, you said 20%, right? 20% failure rate. Okay, that's unacceptable, let's say. But you still have to worry about statistical significance, because in the early days, when you only have a few patients, your estimate of the recurrence rate may be very unstable, and you may be unsure if that's really correct or not. But I think the situation you described is one where you, given a threshold, and it could be at least partly statistical, it could be also based on the observed effect or the recurrence rate in your case, you have to put all that together and decide if you're going to stop, but it's stopping for harm. In other words, the treatment just isn't working as well as the control. Yeah? Yeah, okay. I don't think you said anything that contradicts anything that I said, except that it's talking about harm, and here we're talking about benefit, right?
But it could also have been that peak.
Yeah, of course, of course.
I mean, you overreacted.
Yes, that's right.
Because they have defined the rule as 5%. It's already 20%. So this clinical significance would have been statistically significant.
Exactly.
Well, no, wait a minute. No, let's say I have 5 patients in that group and one of them had recurrence, that's your outcome, right? That's 20%. How sure are you that that's the case? Let's say I had 2 patients and one of them has recurrence, that's 50%. Are you going to stop? Would you stop with 2 patients? I'm telling you the recurrence rate's 50%. It's terrible. You see the point? Yeah. Yeah, you see the point. And the N is important, and of course the N tells you about the significance, right? Whether that's a sufficiently reliable estimate of your outcome, right? So I don't think you can just say, oh, well, we saw this and it didn't look good and, you know, it seemed to be clinically important. Sure, it's important, but you've also got to take the variability into account. Otherwise, you could make one of these very early stops that really isn't justified, right? And if you carried on with another, you know, instead of 2 patients, let's say we had 20 patients, then the whole situation could be different. Yeah. Okay. I do need to move on because these are good discussion points, but we're nowhere near going to get through everything if we keep stopping it for a long time. So, burning issues, yes, but slightly smouldering issues, wait till they break out in a bit more flame. Okay, this is roughly what it looks like with this flexible approach. Again, we're talking here about the so-called information fraction. That's the percentage of patients or outcomes that you've observed in the study. And these are examples of how you can spend your 5% budget. So as it says in the legend there, if you can read it, the first one, this alpha 1 over time, means that you're spending very little at the beginning. So you have a really small p-value for the first, the interim analyses very early on, and then gradually you use up the 5% in later analyses, and that's actually the O'Brien-Fleming rule, with a very conservative test at the beginning. The third one, this one is uniform spending. So you just, every year you spend a certain amount of your 5%. And the alpha 2 is the Pocock rule. So you spent more, it makes it easier to stop, of course, with that less conservative rule. And those are just particular examples. This is how those particular rules fit into the flexible plan. But you can actually go in and use the calculations, do an analysis early, an interim analysis, and then decide whether you want to continue with interim analyses or just keep the rest of your alpha in the pocket, okay, till the end. You can make the decisions as you go, depending on what you see. Okay, so now I'd like to just shift gears a little bit and just to remind you of the outline. So we've done one topic in just about an hour, and there are 5 on the menu there for an hour and a half. So we're not doing very well. We may have to stop early. So let's have a look now at some of the literature on trials that have actually stopped for benefit. And I'll be referring to this particular publication that I was involved in JAMA in 2010. And this comes from the so-called Stop It study group. So this is actually Stop It 2. There's a whole series of Stop It studies. So it's stop it. Okay. So this is looking at the particular subgroup of trials that did actually stop for benefit and what it says about the estimation of the treatment effect. So just in brief, this is what we did. The eligible trials were those that had stopped early because of something in favor of the experimental intervention. That's what we mean by benefit. We did extensive database searching. This, of course, is a very labor-intensive process. We had, pretty well standard for this kind of thing, we had data extraction in duplicate with 2 independent assessors of each trial to see if they were eligible and then to actually get the variables that we were interested in from those trials, and resolution of disagreement between the data observers. In this particular analysis, we ended up with 98 trials that we had found, and it's quite interesting. It's a little bit old now. I think this needs to be updated, but there did seem to be a slightly increasing trend over time of trials that had stopped early for that reason, for benefit. So it's pretty rare back in the 1970s and 80s, but it's getting more common now. One of the major things that we found, and this is quite common with reporting in general, is that, at least half, more than half of them didn't tell us what the planned sample size was. There was a failure to tell us whether this in fact was an interim analysis and whether the stopping rule, such as I've described, was involved in the decision to stop or if it was something else. This gives you an idea of the sample sizes involved, typically 86 events or outcomes for people, and about a fifth of them had used a composite outcome, which of course is a problem. That's another whole area when you're using a composite outcome and some of the parts of that component may not be particularly relevant for an effective treatment. About 3/4 roughly used dichotomous outcomes, and now very interesting findings was that the median effect size, this is relative risk, was about 0.5. That's a big effect, right? 50% reduction in risk. That's a huge treatment effect from what we usually expect. And also the trials that were smaller were the ones that had the larger treatment effects. So there's a suspicion here, because of that, the smaller trials giving you larger effects, there's a suspicion that some of them at least may have stopped incorrectly because of that random high phenomenon. We also were able to compare some of these truncated trials, the ones that stopped early, with other trials that didn't stop and based on the same question. Okay, so we're looking at sets of literature where a clinical trial question was being addressed and some of the trials had stopped and others had not. And this was done by using systematic reviews or meta-analyses. And there we were able to find 91 trials asking quite a number of different questions. Some of them are on the same question, of course. 63 different questions, and we found about 400 trials on the same issues, but that had not stopped. They'd gone to the full target size. And this was the result of that comparison. So if you take the ratio of what was seen in the truncated trials versus the non-truncated trials, we find quite a large effect. So this is a ratio of ratios, right? So we found a much bigger treatment effect among the trials that had stopped versus those that didn't, which is disturbing, right? Because the ones that went to the end without stopping presumably give you a more reliable estimate of the treatment effect than the ones that stopped. So it does seem as though there might be a bias here in the ones that stopped because of this random high problem, and it's quite an important difference. We found that this ratio of ratios here didn't depend on which stopping rule was used, and it didn't seem to be related to quality of the studies either in terms of concealment of treatment allocation, blinding, and so on. And even more disturbing is that in 39 of these questions out of 63, the pooled effect from the non-stopped studies, the non-truncated studies, failed to find significant benefit. So the ones that went to term, if you want to call it that, using an obstetric term there, the ones that went to the full sample size didn't show anything, but the ones that had stopped obviously did. That's why they stopped. So I think you can conclude from that you've got a problem with these studies that do stop early. Okay, any comments on that? I can take questions on that because we're going to move on to a slightly different topic now. Yes, microphone please.
Did you see the reason for stopping with that?
Well, as I said just now, often they didn't tell us whether the stopping rule informed the decision or not. Okay? Well, by this we mean whether there was a formal linkage to, they said, okay, we're using O'Brien-Fleming, and it crossed the threshold. Only some of the studies said that. Usually what they would say is, look, we've got a great finding, a really interesting result, and here it is. Yeah.
Just continue the question, do you need to spell out in your protocol your stopping?
Yes, absolutely. It absolutely should be in the protocol, and it really should be in the report as well, in the published paper, because otherwise it's a pain to go and find the protocol. And interpretation of these studies obviously depends on whether they stopped early or not. You're going to get a different message. And one of the big issues is people often don't tell you. So they said, here's the study. They don't tell you that it actually was stopped because of this early result. Yeah, so that's a big problem of interpretation. Well, I don't know what you would mean by clinical rules. You set up the trial with what you think would be an interesting clinical difference, a treatment effect, but the statistical rule to stop would obviously mirror that, because if something is going to be statistically significant on early data, it's going to be typically, in fact, I think every time, would be a larger effect than your clinical effect. So by definition, if you satisfy the statistical criterion, the stopping rule criterion, it's going to be clinically interesting. It has to be. Yes. Could you use the microphone, because people on the other side of the room cannot hear you. So I don't know if you can get the microphone in advance. Yes.
Can you just clarify?
Could you just clarify on these 63 questions? There was a slide.
Yes.
Yeah,
Oh, all right. This one? What do you need me to clarify?
I'm not quite clear on these 63 different questions.
Oh, all right. A question would be, what's the vaccine protection level associated with this particular intervention? Okay. What's the survival rate with this type of chemotherapy compared to control? So we, obviously, They're in a whole range of clinical research areas, different specialties. Yep, at the back there? Yep. I'm sorry, I'm really having trouble hearing. You're going to have to get the microphone, I'm sorry. It's a accent and a volume level issue.
Do you have any data out of these 98? How many were pivotal trials?
How many were what?
Pivotal for pivotal trials. What do you mean by pivotal? Okay, means the trials which were done like phase 3 trials, which were done.
Phases. Okay, phases. No, we do, but it's actually quite. I was talking about this with somebody yesterday. That determining which phase a trial is in is not always very easy, particularly distinguishing phase 2 and phase 3. Sometimes phase 2 evolves into a phase 3 trial. I would say that the majority, though, you would say is a phase 3 trial. Yeah. Okay, one more at the back there? Yeah.
When you do an interim analysis, does everyone have to have completed that particular amount of follow-up? Say you're doing you're doing an interim analysis of 2 years. Do all participants have to have finished 2 years of follow-up before you do that interim analysis, or is this
no, that's not usually possible, of course, because people will enter the trial at different dates.
Yes.
And so like today, we've got, let's say, 100 people who have finished. They've had their follow-up for a year or whatever it is, but there are other people who are still in process. They only just got diagnosed last week, so those people won't get into the...
So it's just a specified time point, it doesn't have to be the duration?
It's this concept of information. So the information fraction in the end will tell you how many patients out of the total you have, but along the way it's actually how many people have completed and you have outcomes for. So it's that. Yeah. Yeah, that's always the case, of course. You always have this lag. And one of the practical issues, which I haven't mentioned before, about doing interim analyses... Excuse me. One of the practical problems about doing an interim analysis is that there will be a lag time between deciding to do it, like I say, let's do one now. It takes time for the data to come in and be organized. So it might be a month or 2 months from now when we can actually do the analysis and give you a result, by which time, of course, more patients have come along and they're obviously not in that analysis at that point. That's a practical issue and something that you need to consider when you're setting up the analysis plan. Okay. Other questions? Okay. Okay, so here's the third topic, and I think we'll probably not be able to look at it in huge detail, but now a little bit more on the effect of early stopping on the estimated effect size, the estimated treatment effect. And this is an area of active research that I've been involved with. You may recognize some of the other names, particularly Gordon Guyatt, who's a colleague of mine, and he's one of the big names in evidence-based medicine. In fact, he coined the term. So this is going to be looking at some of the theory behind this problem of misestimation of the treatment effect when you do stop early, and then we can talk about how it agrees with what we just saw. So here we have slightly different diagram, but much the same concept, where you've got the early data in all of these 3 studies actually converging to a true beneficial effect. This particular study, though, the one that drops here, would be one where you might consider stopping for harm, because in the early data it's going in the wrong direction, so the new treatment is not favored compared to controls, it's doing worse. And then depending on when you do the interim analysis, you may or may not be over a stopping boundary. So it's the same idea as we saw before. Now, as we've seen, most of the literature on this particular topic has focused on the inferential properties of the analysis plan with a view to controlling that type 1 error rate. That's the false positive rate of 5%. You want to come up with an analysis plan that does still give you 5%. But there's much less on this question of estimation. And it's fairly clear, I think, from what we've said already, that if you stop on a random high early on, you're going to overestimate the benefit. There's another effect which is not quite so obvious, which is if you do these interim analyses and fail to stop, you're actually going to slightly underestimate the benefit. And that's because on average, the ones that stop are over. It has to cancel out in the other direction for studies that do not stop. And then finally, putting all that together, let's say you have a protocol with a stopping rule, and you may or may not have stopped early, there may be overall bias that's induced. So just by having this analysis plan in your protocol, you may actually have induced bias, even if you don't stop. Which is a rather disturbing question and disturbing point, and you have to think about this if you're going to put interim analyses into your protocol. So what we've done is we've actually developed some analytic expressions, some theoretical expressions for these various things. So the kinds of things we're interested in is how bad is this? How much do we overestimate the treatment effect in studies that stop early? How much do we underestimate if we don't stop? What's the probability of stopping? That's an interesting question for administration. Is there overall bias in the studies? And then there's a related question, which is if you've got a series of studies on the same general question, the same clinical question, how much weight will the stopped studies have in a meta-analysis? So you may have an early result with a spectacular result. How much does that influence the pooled analysis from a meta-analysis? Okay, just a little bit of theory now, so people who don't like algebra can take a quick nap, and we'll wake you up in a moment when we get to numerical results. Basically what we do is just for simplicity, we assume a normally distributed outcome, a continuous outcome, which sounds like a bit of a limitation, but in fact it's not really, because even if you have a binary outcome, a yes-no result, everything gradually converges to an approximate normal distribution for the group of people in the study. So using a normal outcome will actually approximate more or less any kind of outcome, including binary, including survival data, and so on. And what we're going to do is we say, well, let's just imagine we have one interim analysis and we stop if we have a test statistic that exceeds a threshold value. We call that Z star. And that is defined by the alpha level that we put into the plan, defined by the stopping rule. So again, just for simplicity here, it goes easily to two-sided testing, but for simplicity, we say that this probability is alpha star if it's Z exceeding the threshold value. Okay? And corresponding to the Z statistic, we have a critical effect size, so that's what we actually observe for the treatment benefit, and that's a function of the critical test statistic and the standard deviation of the difference. And it turns out we don't have to worry about the particular value of sigma, the standard deviation in the data. It's just a scaling issue, so we can just take sigma equal to 1, and we don't lose any generality. So the key result that we used, the theoretical result we used, is you can actually find out what the expected value is from a normal distribution with mean mu, standard deviation 1, if you truncate it. So we can allow for truncating above or below, so we might have a set of studies that are above a certain threshold, and we can think about one or two-sided testing with truncation above and below, so we could stop for benefit above or stop for harm below. And this is the algebra that tells us what the key finding is. So the expected value of the test statistic is equal to the true value, the mean, plus this lump over here, which has to do with where the thresholds are. So in general, you're not going to get the same answer. You're not going to get mu because you have this other component. So that's the theory using the algebra. The algebra hating people can now wake up again. We actually evaluated this for a set of scenarios that we think corresponds to real trials based on empirical evidence. So we had the mean, this is the treatment effect, varying from 0 to 1 standard deviations. 0 is obviously zero effect. 1 is a massive effect. And typically we're planning studies with deltas or effect sizes typically around 0.2 to 0.5. 0.5 is sort of a moderate effect, moderately large effect. 0.2 is a relatively small effect. But we looked all the way up to 1. And we took sample sizes between 100 and 1,000, and we defined them as small, medium, and large, with 80% power for these effect sizes, which from other literature, people sort of conventionally regard these as large, medium, and small effects. So you need a large trial for a small effect, and so on. We also looked at 1 or 2 interim analyses with those 3 stopping rules that we've seen being used in practice. Okay, and this is just a repeat of what we had before. Those are the stopping rule boundaries. And then again, just a little bit of algebra, and then we can come to some numerical results. This is how things turn out as a general expression. So if you have a study that stopped at 1 interim analysis with one-sided testing, this is the expression that you have for the mean in those studies. So you don't need to worry about the details, but what does this tell you? It's mu plus something. So the thing on the right there is the overestimation. So if you stop early for that reason, you're going to overestimate the benefit. If you have a study that doesn't stop, it does an interim analysis, it doesn't stop, you have a corresponding expression, the true value minus something, so you're underestimating in that group. Then the mean in studies that don't stop and get to the final analysis, this is their expected value, so you're still underestimating at the final analysis. This is the probability of stopping, which we can look at, and this is the mean weighted by the probability of stopping. So it turns out that the overall effect of putting a stopping rule in is to overestimate. There's a positive bias. Interesting finding. And then this has to do with the meta-analysis, the expression for the weight of stopped studies in a meta-analysis. And you can go on and generalize all this if you want to look up the details for two-sided testing and two or more interim analyses. But let's have a look at what the numerical results show us. And if you're interested, you can go to the paper, and we've got tons of tables like this, which I'm sure you'll be able to summarize very quickly. So here's an example. If we had Pocock rule with one-sided testing, and the true value is 0.2, a rather small effect, and we had a sample size of 800, this tells us that the overestimation would be 0.07. So compared to a true value of 0.2, we would be saying on average it's 0.27, so it's substantially higher, right? So that's the degree of misestimation. Let me just summarize what all that says. It turns out that this problem is more of a concern if you have a small true effect, that's mu being small, or if you have a small study, which sort of makes sense. If you have a small study, you've got less information, it's more variable, and the overestimation will be more severe. But even if you have a big study, it can still be a problem. So here's an example with similar to what we just looked at. If you have a sample size of 800, quite a big trial, with the Pocock rule, if the true value is 0.2, the overestimation is 0.07, as we saw in the table just now. And if it's a smaller effect, 0.1, the overestimation is about twice that. And that's equivalent to overestimation by about a third in the first case, and almost 150% in the second case. So really severe misestimation. So this is something that you really need to take on board. That if you see a study that stopped early, and you're looking at how much benefit the treatment seems to have, you've got to recognize that could be a pretty severe overestimation. And this, I think, is the big take-home message. The greatest concern is actually for those studies that do actually stop. For your interest, and you can look at these in a bit more detail, this shows you how things go for the various rules. So we've got Pocock, O'Brien, Fleming, and Hay-Bittel-Pito. On the left, you've got one-sided testing. On the right, you've got two-sided testing. And the 3 lines are for small, medium, and large-size studies. And so you can see for one-sided testing, the overestimation gradually goes away if you have a big enough true effect. Problem is, of course, you don't know what it is. That's why you're doing the trial. You actually don't know what the true value of the effect is. So we can't actually say exactly how big this effect is going to be. You can see that the bias or the overestimation is more of a problem in small studies. That's the top line. And again, this may be something that doesn't show up very well in your black and white printing. So the top line is the small study. The bottom line is the large study. So you're pretty well okay with much less of an issue in a large study. So we have that monotone or constant trend with one-sided testing. Well, it's interesting with two-sided testing. It's a little more subtle. The overestimation seems to happen. The worst case scenario is at some intermediate value. So if you have a very small effect, no problem. And if you have a large effect, it tends to go away. But somewhere in the middle, you have this misestimation occurring as well. So once again, you do need to know what people actually did. You do need to know whether it was one-sided or two-sided testing to evaluate how much of a problem this is for you. Everybody okay so far? Okay, good. Now we can look perhaps a little more quickly at underestimation. Again, there are cases where you might have a problem here. So this is the same one, 800 with Pocock. Depending on the true value of the effect, we do still have some estimation problems, so it's about 17% or 22% in those two cases relative to the true effect. So it's quite important. You're actually underestimating the benefit, even if you go to the full sample size. This problem of underestimation is more serious, again, if n is large or mu is large. But in those cases, you're less likely to have this happen. You're less likely to not stop. Because if it's a big sample and a big effect, you're much more likely to stop. Right? Because it should be a little more obvious. And this is how it looks for the underestimation issue. So you can see a little bit of difference between the small, medium, and large studies, and as a function of the true treatment effect. It gets worse as the true effect gets larger. So this is underestimation, negative. Not too much difference in this case between one- and two-sided testing, interestingly. Just to summarize the probability of stopping. So it's highest with the Pocock rule. Remember, that's the one that had the largest type 1 error rate at the very first interim analysis. And it's smallest with Hay-Bittel-Pito, which required the greatest significance in the interim analysis. You're more likely to stop if you have a large sample, and more likely to stop if you have a large true effect. And probability of stopping is a little bit smaller with two-sided testing. And here's how that looks in general between small, medium, and large studies. Again, you may need to label these graphs. They all go in the same direction. This time, the small studies are less likely to stop. They're the bottom line, medium, and then large studies on the top. So you can see, actually, for some of these cases with moderate or a very large effect, you're quite likely to stop, in fact. And calculations like that, of course, are useful for your budgetary planning, because if you're likely to stop, you stop the spending as well. Okay, and then the last one of these is looking at the overall bias. So this is if you have a study with a stopping rule and you're just planning one interim analysis, what's the overall bias that introduces, irrespective of whether you do or you do not stop. So you can see again we have perhaps a little more of an issue with small studies. Here with Pocock, for example, you've got more bias introduced, but if you use the Hay-Bittel-Peto, less bias for moderate or small effects because it's a more conservative rule to stop at the interim analyses. Okay, so you can think about those in a bit more detail. Just to summarize all of those, the overall bias goes down with large samples, and the fixed sample size, if you're planning a study with a particular size, there is a maximum bias that can occur at some intermediate value. It turns out it's not too serious. It's about 6%, for example, with a sample of about 100. But can be bigger, obviously, in a bigger study. Relative bias, relative to the true effect, it's about 10%. Okay. Differences between the stopping rules are quite minor, but the Pocock has a maximum bias at a smaller treatment effect than the others, and so on. And interestingly, they all have small positive bias when there's no effect at all, when mu is equal to 0. So if you have just this one interim analysis, one-sided testing, there's actually a little bit of bias for all of the stopping rules. Okay, I think in view of the time, I'm just going to skip over a couple of these, talking about two-sided testing. This is the maximum possible bias. And very interesting theoretical result. It turns out that this maximum absolute bias for a fixed sample size doesn't depend on the stopping rule that you use. You can use any stopping rule at all, and the maximum possible bias is given by this amount. So a small study has a larger worst case scenario, of course, and a large study is relatively small. This is where it happens. So if you have a small study using Hay-Bittel-Peto, you really have to have a massive effect going on before you have that bias, whereas in large studies with Pocock, for example, it's a much smaller effect where it would occur. The relative bias, this is what I showed you just now, it's say about less than 10% with Pocock and even smaller with the other two rules, being slightly more conservative. So that's a take-home figure that you can quote to your colleagues. If you put a stopping rule in, you're going to have a relative bias of about 10% automatically. And this is something that's not generally quite well appreciated, I think. Just a little more on the numerical findings, and then I'll do a skip over, I think. We need to get to other material. This shows you what happens if you change the power. So we usually, or very often, will adopt 80% power, and that's the top. That's the top graph there. If you change it even as high as 95%, you gradually push this bias downwards, but it's still there. It's not a massive effect, interestingly. You push it down a little bit, and you move the worst case scenario down a little bit to the left to smaller true effects. So obviously improving the power is a good thing generally, but it won't have a huge effect on this bias. It's still there. Okay. The other slides here are talking about meta-analyses and two interim analyses. I think in the interest of time, I'm just going to skip over that. Just to briefly review, summary. So studies that stop early often overestimate the treatment effect quite substantially. That's also the case for studies that have a stopping rule but don't actually stop. So you still have a problem there with underestimation. And these are our sort of guideline values. The overall bias, less than 10% with one-sided testing, a little bit bigger with two-sided testing, but can get worse with smaller sample sizes. And we can extend these ideas to more than 2 interim analyses, and things actually get worse generally as you have more interim analyses, as you might expect. You have more bias and more problems with estimation. Now, having found that there's a bias, can we correct for it? And this is a very common question. Can we just say, well, we can estimate what the bias is and take that away from the observed effect? Well, no. Unfortunately, the bias, as you've seen, the amount of bias depends on the unknown parameter, which is the truth, what the true effect is, and we don't know what that is. So there are some correction methods that exist out there, but you have to make some assumptions that you can't verify about the past data, and you certainly can't verify anything about future data if you stopped, because you don't have the data. And it turns out that although those methods are out there in the theoretical literature, it says here they've not been widely used in practice. When I made that slide, we thought that maybe there will be some examples where they had been used. In fact, we haven't found any. We have, after really searching these things, we've not found any good examples of where these corrections have been used. Some of these methods are Bayesian, if you've heard of Bayesian methods, where you assume something about the possible treatment effect before you start, your prior distribution. I'm not a Bayesian, so I hands off at that point. But the Bayesians don't actually need data, they kind of make it up. You don't, in fact, have to do a study at all if you're a Bayesian. You can just use your prior. I'm being very cynical. Okay. And a general comment is that doing analytic investigations like this with algebra, I think in a way it gives you more insight than doing simulations or even looking at the literature, because you can see what everything depends on theoretically. Does it depend on the true value? Does it depend on the sample size and so on? You can actually see how all those components come into play. And you also avoid the necessary interpretational problems when you look at particular literature. There are always extenuating circumstances or covariables or factors involved in the studies that complicate the interpretation. So in a way you get a cleaner cut through the problem with an analytic approach like this. But it turns out that the results that we have, I'm not going into details here, but what we have theoretically turn out to be quite close to what we saw in the Stop-It study, the Stop-It surveys. So that's very encouraging. Okay.
Clinical trial.
Yes.
Set 4 time points. 45%, 50, 70. And first increment, second increment, we can stop the trial or we will start again.
I didn't hear the last bit of your question. You said we can go at 20% and so on?
First increment, second increment. We found the significance. So we have to...
You did the first interim analysis and it's significant, okay.
Yeah, at the 25% of intake, we found significance. At 50% also we found significance.
Okay, when you say significant, you mean you crossed the boundary? You crossed the threshold, yes?
Yes.
And what's the question? What's the question?
So can we stop the trial or we have to reach the...
Well, of course you can, yes. That's the whole point of doing the interim analysis. That's your decision, yes, you can. They're actually called stopping rules, but they're really not rules, they're guidelines, because there are other things that come into play. But if you followed the statistical threshold as a rule, and it's over the threshold, then yes, of course you'd stop, otherwise why would you do the analysis?
Okay.
What is your doubt about that?
Yeah, same thing only. Same thing only, that is okay. And which one is advisable? Plumbing rule. That one or Pocock is almost, it is constant over the time.
Yes, Pocock is the constant one, yeah.
Yeah, so which one is advisable? Which software we can use it to calculate?
Which one? You have to choose. I've told you what the issues are. With Pocock, you take a bigger chance at the beginning because you don't have to have such a small p-value. But if you just want a little look and take a little risk of stopping, you want to be very conservative, and it has to be a very big effect before you would stop, then you take one of the other ones. Right? O'Brien Fleming does that. So that was the one that had the 0.00001 to stop at the first analysis.
Okay, which software we can use it this thing?
Which
Because
software?
We can use it to this thing.
Well,
We can calculate.
I've given you the table of the values there, and then they're easy to look up for other numbers of interim analyses, or you can use the website that I gave you for the flexible approach.
Online website, online calculation for that.
Yes, try it. Go on the website and have a look.
Because we don't have that SAS or something, so any other or it has that.
Yeah.
Next topic.
Yeah, okay, so that's the plan. Because this obviously seems to be a topic of quite some general interest with a lot of questions, we decided to modify the timetable just a little bit. So I'll just spend a few more minutes going over the slides here, and then we can have some general discussion. And then we have the next topic will be before lunch as well on the step wedge design, which will be jointly with myself and Jaya Seelan, okay? So please just let me finish the slides, and then we can talk about the papers, and then we can have some general discussion. Okay, so this is where we were. And so we've now done 3 of the 5 topics, but the other 2 are much shorter, so we should be okay. So the next issue is stopping for harm, which is in some ways quite similar to stopping for benefit, just in the opposite direction. Although, of course, your threshold for stopping for harm might be a little more, might be easier to stop for harm than stopping for benefit, for obvious reasons. So, stopping for harm then, as I just said, you tend to err on the side of caution, especially if you're talking about harm from side effects, and that may mean that instead of having say plus and minus 2 standard errors, you might have asymmetric boundaries. You might make it easier to stop on the harm side than on the benefit side. And again, you can be very flexible about that. If you use the calculators on the internet, you can define those however you wish. So you might want to be very conservative and only allow a big effect for benefit to stop you, but allow a much more moderate effect to stop you for harm. So your general concern is that the experimental treatment might be worse, or that it might have more side effects. Those are the 2 major reasons that we refer to as harm. Let's have a look at a particular case, and we can discuss what you would have done. This is a placebo-controlled trial of probiotics in people with acute pancreatitis. And in fact, this trial did continue to the end, but it was criticized because some people alleged that it should have stopped earlier. And we'll see why in a moment. So there was quite a lot of publicity about this trial, and there were allegations that the DSMB, or the DSMC as it's called there, had been negligent by failing to notice an early trend of increased mortality in the treatment group at an interim analysis, and they also said that the wrong statistics had been used. Well, I'm not going to go into that particular issue, but let's look at the increased mortality question at the interim analysis. And as I mentioned at the beginning this morning, this opens up the possibility of legal action, because relatives of people who had died in the trial launched lawsuits saying that they shouldn't have been on the inferior treatment at that point. So let's have a look at the essential data from this trial. So as I said, there's 2 groups, the probiotics and the placebo. And this is what happened in the first row here at the interim analysis, with the outcome being death. So you can see that in the probiotic group, that's the experimental group, there were 15% deaths, and in the placebo, 7%. Okay, so more than a doubling of the death rate in the experimental group compared to placebo. But despite that, the trial carried on, and by the time they got to the completed sample size, the effect, if anything, was even more. 16%, quite similar numerically, but the ratio was greater, 16% to 6%. So the event rates stayed about the same, as close as they could be actually, within those groups on much larger sample sizes. And in terms of statistical testing, I actually did my own calculations on this because I wasn't totally sure how they got at the results that they had in the paper. That might have been the wrong statistics, I'm not sure. So at the first interim analysis, the overall significance level was 0.097, so not significant. The upper end of the distribution, the one-sided test, was 0.038, so that was significant. But when we get to the final analysis, we have a p-value that's just less than 0.01, and both of the tails are very small probabilities, so a fairly definitive result at the end. So just to review then, the allegation was that this trial should have been stopped earlier because of this effect, and the committee was, and the investigators were criticized because the people who remained on the probiotics obviously had a continuing higher death rate than they would have done on placebo. So what do you think? What would you have done? What are some of the arguments in favor of stopping or not stopping at the interim analysis in that trial? What's the argument in favor of stopping? Oh. Sorry? The mortality is greater in the treatment group. That's right. Yes. Anything in more detail? You can't just stop because it's greater. How much greater? It's a lot, right? There's a doubling of effect. So it's a very big treatment effect. This is what you would, I'm sure, think of as a clinically important effect, either in absolute or relative terms, right? In relative terms, it's more than a doubling. So that's the argument in favor of stopping. What's the argument in favor of not stopping? Yes, statistical significance. Exactly. So the overall two-sided test is 0.097, which certainly doesn't meet the usual criterion, even at the 5% level. And remember that this is an interim analysis where we should have controlled the type 1 error rate by having an even more stringent threshold. So you'd require an even smaller p-value than 5% to stop at the interim analysis if you had a protocol in place for that. So that's the argument against it. So apparently, there were obviously other factors in play, but apparently in favor, in this case, they were in favor of following the rule that the threshold had not been met, and so therefore they're thinking of this difference between 14 and 6 deaths, and when you think of it that way in terms of frequencies, 14 versus 6, that's not a lot of data. So that's presumably why they did what they did and carried on. And as it turned out, that was presumably the wrong decision. They should have actually stopped. But that, of course, is hindsight. It's absolutely hindsight. And this is the dilemma that you face. Some of the time you'll be right, some of the time you'll be wrong. I don't know if anybody else has other comments on that one, but if not, okay. Oh, yes, okay, go ahead, quick. Microphone? Yeah. Burning issue only. And then we'll go to general smouldering issues after that.
Sir, there is no burning issue, but I want to say, like, for example, similar, like this harm results at the completed trial might be similar to the interim analysis of the first example you have shown me with regard to efficacy. Is that a possibility? It might be a possibility.
Well, it's different from the first example. You mean the cancer trial? In the cancer trial? Well, in the cancer trial, what happened was it was looking very significant at the beginning, but then it drifted away and you ended up with no effect. In this one, you start off with a big effect, but it persisted. So
that is what I am saying, sir. So the completed trial results, might be actually the interim study results of those that AML trial. This might be an excursion on the harm side. It might not be a true effect, it might be an excursion on the harm side.
I think it's the same issue. It's just that in this case we're looking at the other side. It's a trend against the experimental treatment instead of in favor of it. That's the only difference.
Yes, because even at this time, there are not sufficient number of events of death in probiotic versus placebo. Even at the
You don't think this is sufficient number?
sufficient number of events, like similar type of events were
Oh,
there
I
in
see. You
interim
mean?
analysis.
Oh, I see. You mean that if this trial had gone even longer,
Yes, sir.
that it might have gone away. Oh, yes, of course. We can never be certain about that. Yes, that's quite possible. Yes. So it would be similar to the other trial if that happened. Yeah. But who knows? Who knows? Yeah.
So, was that adequately powered?
Don't know. I'd have to look back on the details of that. But again, once you've done the study, the power issue is out of the off the table, right? This is the data now that we work from, so power is irrelevant. Yeah, I'm going to stop discussion now because I'm very concerned we're going to take away from Jas Seelan's time. So we will have some time for general questions and other doubts in a moment. Some of the recommendations coming out of all of this, it is a good idea to have a DSMB with established roles, who does what. And in talking to one or two people, somebody said, well, if you do an interim analysis, doesn't that affect the conduct of the trial after that? Actually, the interim analysis should be confidential to the investigators. It's usually done by an external person or a statistician on the team who keeps away from the other investigators. So the results of that interim analysis are not revealed to the investigators because obviously that could affect if they knew what was going on. However, there is a very subtle point that if you're an investigator and now your DSMB has done an interim analysis and they come back to you after that and they say, carry on, there's actually a message in that because it tells you that you did not stop the trial. So that in turn tells you there's no big effect happening at this point. So there's a little bit of information even in the fact that you did the analysis and you get the result in terms of carrying on. So that's a tricky point. But you should be able to, if you've got a properly designed trial, you should have all this in place with stopping rules, although I think more correctly they should be called guidelines because there are all these other factors that come into play when you're deciding whether to stop. Have a good target sample size, that's the completed sample size, and with defined stopping rules. One of the things we found in a survey, which I'll talk about tomorrow, on futility, is that when you looked at the reasons why people stopped in a literature survey there, it really wasn't clear whether the boundaries were in place beforehand or not, or whether they kind of made them up once they saw the data. It was very, very unclear in many of the reports. So it's much cleaner and much more solid in terms of telling the story if all of this is worked out in advance. And just to re-emphasize the point I made earlier this morning, that if you do have a stopping rule, it is going to affect your treatment estimated benefit, even if you don't stop. And it's a big decision whether you're going to stop. And quite apart from whether you've crossed the threshold, you need to think about all of these other things that might have caused the apparent effect. So covariables, even though you have randomization, it could have got unlucky and there could be imbalance on those covariables between the treatment groups, so you need adjusted analyses to the extent that you can do them. We heard all about all these possible ways that bias can come into the trial in general. Think about all of that. Is there any missing data that could affect your conclusion? Differences, that's differences between treatment groups in adherence to treatment and other interventions. You often find that one treatment is more likely to have co-interventions than the other. Is it a consistent story? Is it consistent across subgroups, for example? Although that's a tricky area. Certainly, is it consistent across centers? If you find big differences between centers, that could be a warning sign that something funny is happening. External evidence, other trials that have either been done before or currently going on. Credibility, if you stop early, is it actually a believable effect, especially if it's a very large effect size? And a critical thing is potential impact on future research. If you have a dramatic finding that says treatment A, this new treatment is much better than the old one, that's likely to be adopted, go into clinical practice, and nobody will be researching that question for some time till somebody says, well, I'm not sure I believe this anymore. So it actually has a big steering effect on what happens afterwards. You need to think about that too. So in many ways, it's often better to keep going. If you're in any doubt about any of these things, then it's often better just to keep going, but then you run into the problems as we saw in the probiotics trial. Okay, so next and fairly briefly, the examples that we're going to talk about. This is the last item on the agenda. So in the set of papers that you have, there are 4 papers. I'm sure you've read them all in detail overnight. There are 4 papers in completely different clinical areas. All of them stopped early, and it's up to you, each of you, to decide which one you're most interested in, either from the point of view of what the clinical area is or because of what the study looked like methodologically. You're going to be formed into teams, and you may or may not collaborate among the team. Read your paper. That's a pretty good requirement. And what I'd like you to focus on is not the super details of all the procedures and the rest of it, just the essentials of what the design was, what the basic question was, and particularly focus on the author's rationale for stopping early and decide if you'd agree with their stop. Okay? So we've seen a couple of examples already, and you need to go through that thought process. Jai, you had a question? Jai?
Yes, these papers are after the green color sheet.
Yes. Yes.
In your book, there is a green color sheet after that journal review or critic.
Right.
There are 4 papers.
Right. They know that because they looked at them all last evening. Okay, so just to make sure this is going to work, I'd just like a show of hands, roughly to get numbers with no commitment. I'm going to ask for each of those papers in turn. The paper on depression by Kalb, how many people are most interested in that? Okay, just a couple of people, 3 people, 4 people, okay, 5 people, 6, oh, they're coming out now. I was going to say it's a bit depressing, but it's not. The surgery paper, 2, okay, only 2 people. Infectious disease one, quite a lot, okay, no problem there. And the arthritis one? Okay, so it's just the surgery one people don't seem to be particularly interested in. So. I don't think we need to do any rearrangement, but do come along tomorrow, prepared to, one of you people, to make a very brief presentation to the rest of the group on these points, what the study was about, what the essential details were, why they stopped, and whether you agree. Okay? And we'll spend 5-10 minutes on each paper tomorrow. Okay? Everybody clear? Okay. Good. Okay, so now before we start on the stepped wedge design, which is the main topic for this particular time period, we can now have a little bit of general discussion. I know a lot of people said they've got doubts. Would you do this if I did this study and so on and so forth? Now is the time to ask those questions about stopping early. Yes. Take mine.
My question is that these stopping rules, do the regulatory authorities follow it strictly, or they take a holistic view? Because this has got its own response, as we have seen. So, regulatory authorities, especially for phase 2, phase 3, I mean the FDA and equivalent, do they give adequate importance or complete importance just to the stopping rules of statistics?
Well, okay. I wouldn't say they're rules in that sense. They're not mandated by FDA or anybody else. I think studies are more convincing and they're more likely to be approved if there is a protocol that includes a stopping rule, if it's relevant. But it's not, it's a guideline. So if there's a defined process ahead of time to make that decision about stopping, including the statistical criteria that we've talked about, I think it's a more convincing thing. But it's not something that you can hold people to. There are certainly many examples where, well, we've seen a couple of them, where the threshold was exceeded, and on that basis you should have stopped, but people didn't, or vice versa, that studies stopped even though the threshold was not met. So, and there's no criticism for that. Yes, yes, yes.
No, my query was specifically, there could be a vested interest by the industry where I plan to do an interim analysis primarily that if I get an efficacy result early, I will be saving on the cost. So shouldn't be the regulatory authorities be guarded that one shouldn't be too eager to accept efficacy at the earliest and wait for the entire population size.
Okay, so you've raised the issue of the involvement of the funders, which, yes, is a concern because you probably know that if you do meta-analyses and you look at the source of funding, industry versus non-industry funding, you find quite meaningful differences in the results. And so requiring or thinking about an early stop because the results are encouraging would be very appealing to an industry sponsor, perhaps less so to a non-industry sponsor, yes. So once again, I think if it's in the protocol, it's more convincing. If there's a defined rule for stopping, and ideally, and in fact in our industry-sponsored studies, we are independent of the industry. We can do what we want. It's not the industry sponsor that makes the decision. That's one defense against it. Question at the back? Yeah. I think you have to put, yeah.
Do these rules also apply for, say, a prospective cohort study? The same rules and the same trade-off between, the alpha spending. For example, if you're looking at, like, I've got a study in which I'm looking at donors who are impaired fasting glucose and seeing how many of them become diabetic. It's not standard policy to accept these donors, but if we see that, it's beyond the population average, is it the same? Do you use the same rules?
Okay, so you're asking about non-randomized observational cohorts. Yes. Okay, in principle, you could use exactly the same approach, no problem, but because it's not randomized, then you have the concern about all these other issues such as bias and so on, missing data and all of that, much more so than in the context of a controlled trial in a clinical environment. So I think you would probably be more reluctant to stop in a cohort study like that than you would be in a randomized trial because of those concerns, that there could be other reasons why the effect is becoming obvious or showing up in the early data. So, but you could certainly apply the same stopping rule protocols to those kinds of studies. Yes. Yes. Yeah. Here maybe? Yeah.
Sorry, probiotic trial, sir. Sir, it is 14 versus 6 in interim analysis.
Okay, what was the question?
Yeah, sir, in interim analysis, it is 14 versus 6.
Yes.
So, if we compare that, sample size is also equal and it is 50% near about.
And your point is?
Sir, 14 deaths are there, sir. Since if we see that adverse outcome or something, means, as compared to that, death is very crucial point to discuss about it. So if we, what sir said that if we go for interim analysis again and again, if we increase sample size, why to wait to make for those deaths to happen? Why we are not thinking about here that 14 and 24, 10 difference is there, 10 death difference is there. So why we are not thinking about differential diagnosis? So my question is that again.
Differential diagnosis, sorry, where did that come from?
Okay, sir. Yeah. So my question is that, my question is that when right now, tomorrow we will discuss about it and we will think that interim analysis when to stop, means that our, 1 or 2 or when to stop. In that case, all these statistical guidelines we will think about it. So always we also think statistical versus clinical significance. So in clinical significance, when we are thinking, are we going to think about that clinically? Should we stop or not? Are we going to think about that? Again, I'm talking about differential diagnosis.
Okay. I don't understand what you're saying about differential diagnosis, but let me try and answer your question anyway. What you seem to be saying is you're very impressed by the 14 versus 6.
Yeah, so since it is about death, so
and
for example, personally, I would not think think about statistics, because statistically 14 death is very crucial, sir.
You mean because it's death?
Yeah,
Yeah, because it's death. That's a pretty important outcome. Yes, okay, fine. So your perception is, if you were on the committee making the decision, you would be saying, look, it's 14 versus 6 deaths. That's really important, and it's more than a doubling of risk. In absolute terms, it's important. It's what, 8% difference, that's important, and a doubling in relative terms. So we've got to stop. Absolutely fine. But what if, let's say there had been an earlier analysis, and there were 2 deaths in one group and 1 death in the other. Okay, that's a doubling of risk as well. By your argument, you would stop, without regard for the fact that that's obviously a very early result and it's not very stable. Can I just answer your question? This position here, at this interim analysis, is somewhere in between, right? Because you've got a big effect. It's not a huge sample, but you've got a moderate number of events. But you're still concerned about the statistical uncertainty, and that's shown by this lack of significance down here. So you can't obviously just look at the clinical effect in isolation, because if you did it with just a couple of deaths, it would be ridiculous, right? 2 versus 1, there's no way you would stop the trial. And I still don't understand the bit about differential diagnosis. You can answer it. Good. Good, ma'am. Answer the question. Okay.
For example, the mortality the mortality in this disease patients is around 10%. If you club the patients, 90, 100, 200, out of 200, how many deaths? 20. This means 10% mortality. If you are not giving any treatment, the patients are getting 10% mortality. And now again you are getting the 10% mortality. This means...
No, if they're not, no, wait a minute. If they're not getting any treatment, at least if we assume 0 placebo effect,
so it's like
it's about,
excuse
me, you said if they don't get any treatment, the death rate is about 10%. That's not right. If we assume if you assume the control group or the placebo group is, effectively no treatment, then the death rate is actually only about 7%.
No, sir. Actually, it's like we are not analyzing. We are doing an interim analysis. For example, if we know that the mortality rate in this particular disease is around 10%.
And where do you know that from?
So we do it from historical data.
Wait. Now you're saying there's other information that you want to bring in, which is fine. Yes, but we still have to look at this because this is tightly controlled, randomized study. And if you're saying, there's historical data, that could be different. It could be different patients and so on.
So we can't rule out what is actual mortality rate seen in the humans. For example, there is one trial with regard to a TB drug that is known as bedaquiline. In bedaquiline trial, it has been seen that there was around 23% mortality in bedaquiline group as compared to around 7% mortality in placebo group. So bedaquiline should not be approved for treatment of TB, MDR-TB, but bedaquiline is approved for the treatment of MDR-TB. So it is a random error because the overall mortality in normal population of MDR-TB patients was seen to be around 10%.
No, I'm sorry, but wait a minute. I have to disagree with that because if you look at previous patients, there's a pancreatitis, right? We haven't seen all the details in this trial, but there are going to be inclusion and exclusion criteria. For example, no comorbidity, you might have age restrictions on the patients and all of that, which all of those things could mean that you have a difference in the expected death rate in the trial patients versus anybody else in the general population or historically. So I think there are big problems with trying to use that kind of external evidence as opposed to putting a lot of weight on the randomized comparison where remember randomization balances out any known or even unknown confounders.
Randomization can balance only known and unknown compounding factors, but randomized trials are mostly not able to give the real world scenario.
Exactly. That's what it doesn't give the real world answer. It's kind of a criticism of trials, but if it's true, it means you can't rely on the historical evidence because they're a different population, right? I need to move on to somebody else. I don't want to let one person dominate, so let me have another question.
Sir, I want to ask you a hypothetical question. Suppose I am a pharma company. I have a new drug molecule in my hand. I am designing a phase 3 trial, and
close to the microphone. Yeah, just a little bit louder.
I am a pharma company. I am designing a phase 3 trial for a new drug in my hand.
Okay.
And can I take, say, like a liberal stopping boundary for efficacy and more conservative for safety? Can we do that, or do I have to take a single rule, say like habital pito for both safety and efficacy, or can I choose different rules for different?
I think I said that you can use different threshold values for the two sides, and by liberal, we have to be careful what we mean, right? For benefit, you need to make it more difficult to stop. For harm, you make it easier to stop because you're concerned about the new treatment being worse than what people would otherwise get in standard care, or you're concerned about side effects occurring more frequently.
That's what I was asking. Can I do the other way around? Means making...
you want to make it easy to stop for benefit, but not very easy to stop for harm.
Yeah.
Well...
because I am a pharma company, that's what I...
You heard about Rate My Doctor? I think I'm not going to give you a very good review. It's a hypothetical question. It's okay. No, you obviously could do it because these methods are very general, but I don't think that's a very plausible strategy, actually. I don't think you would get that approved. Would you? Doesn't sound like you're going to allow a lot of people to have side effects and for the experimental treatment to potentially be worse. Just keep going, never mind. But you stop early if it's just a small benefit? That doesn't sound... If I was on an IRB, I would not approve that trial. But again, I think, the question is hypothetical, but that's the kind of issue that should be discussed as the protocol is developed and written down so that it's in solid terms, it's in concrete, and people agree on it.
Thank you, sir.
Yeah. Vishali?
So you mentioned about the bias, right? The bias which is about 10% if you do an interim analysis. Now, is it due to the fact that there was an interim done by an independent statistician that you have this bias of 10% in the overall, the final
No, it's just a numerical consequence of the fact that you looked early with the potential to stop.
Okay.
And so the ones that stop are indeed overestimating the benefit, possibly by quite a lot. And when you look at all trials with a stopping rule protocol like that, the ones that stop have quite a lot of weight because they have this real bad overestimation. That contributes to the overall bias. That is why. It's nothing to do with the independence of the investigator or the statistician, nothing to do with that. No. Other questions? Yes, one here. Microphone, somebody? Yeah.
So I just have two quick questions. One is about the control regimen. Suppose you had assumed 85% cure rate in the control regimen, and it doesn't come up to that level during your analysis. So is it important to look at the superiority and non-inferiority margin alone and not give importance to that 85%? Suppose I found only it is 80% or 75% at the end of analysis. What do I do with the control rate?
Okay, so there's two bits to that question if you didn't hear. One is if the control event rate is not what you thought it was going to be at the design point. And the other part of the question was should you be looking at non-inferiority and so on. Okay, first part. If the event rate is different from what you planned, that's a very common thing to happen. And of course that can, in many cases, result in a loss of power. So if the mortality rate, for example, is lower than you had hoped in your design, and unfortunately fewer people died in your study than you had hoped, that will lead to loss of power. And that could be why you get a non-significant finding, as we've seen in some of the examples. When you do an interim analysis like that, you have the opportunity to adapt the design in some way. You keep going, randomizing new patients, but with a recalculated sample size, for example, allowing for that change in what you know. So you're actually using the early data to inform you about the design of the remainder of the study. That's a perfectly legitimate thing to do. And that's called adaptive designs, adaptive study design. And I think we're going to hear a lot more about that this afternoon. This afternoon, yes. So there's a major topic on that. The other part of your question, should we be looking at superiority or should we suddenly start looking at non-inferiority and so on? Again, that should be all decided before you look at the data. You've got to decide whether it's a superiority trial or equivalence trial or whatever at the beginning. You shouldn't really be changing your mind about that based on what you see.
Another question is about, as an investigator, for example, I'm doing a trial with cure rate. Am I supposed
Your microphone isn't on. I think people can't, am I right? People can't hear you.
As an investigator, suppose I'm doing a clinical trial and my endpoint is mortality or cure rate, do I have to keep account of that number? It
Which
can
number?
lead to the number of the outcome. What I'm trying to say is, suppose I had enrolled about 100 patients,
okay,
and 85% of them have got cured. So
okay,
do I do that kind of once in 2 months, that kind of an analysis as an investigator? Will that bias me, or the entire analysis should be done only by the statistician?
Oh, you're asking who does the analysis? Oh,
no,
well, I
because
think
at different forums, when you're an investigator, you will be asked about your trial.
Yeah.
So this many have enrolled, this many have got cured. So
No.
we would have not done a detailed comparison at
No.
all. So
when you go to meetings and people ask you about your trial and they say, how's it going? You say you don't know, because you don't know. The interim analysis will be done by somebody else. Either typically as a statistician on the team, or sometimes it's a job that's done by the external data safety monitoring board. They are the people that will do that. And they may, I've been on some of these monitoring committees, and sometimes what will happen is we get a report of the safety data, adverse event rates and the outcome rates by group, but we don't know which group is which. Okay, so it's A and B, but we don't know which one is which. So we see that. We have the opportunity to ask to be unblinded ourselves. And we, in the committee, we would have that discussion, first of all, blinded, to avoid our own bias, right? Because the interpretation could be very different. You can actually rationalize it. Well, if A is the experimental treatment, then that's why it's going in this direction. But if B is the experimental treatment, that's why it's going in that direction. So you can actually come up with a rationale that you think is right when you know the labeling. But if it's looking like a serious difference, let's say on safety, you definitely want to know which group is which at that point. So the committee would know and the statistician would know. You still don't know that, right? It's only when you get the report back as an investigator, you get a report back from the DSMB or from the independent analyst that tells you you can continue, or we think you should stop, and we'll not give you details because it's for your consideration at this point. We would say something fairly vague, like we have a safety concern with your trial and we recommend that you stop. You will probably then say, oh, that's not enough, I need to know more, and that's fine, that's your privilege, but you have to realize that at the point that you become unblinded, you become terribly biased about the whole thing. And you may have good reason to want to continue because you really believe this treatment works, and despite the safety information, you want to keep going, or you're happy to get rid of it. So your whole philosophy changes. So it's a very difficult question as to who knows what. We actually had a trial that was going on just a couple of months ago where we had a DSMB meeting, and it was a trial in South America, and we had some major concerns about safety. And I felt that we should perhaps stop. It was looking a bit serious, and we had a very, very long discussion. The decision was made actually to keep going a little longer, but to have another interim analysis very soon. So you can have that sort of response. Another one last year I was involved in, where the treatment effect for the major outcome It's a very, very big trial with thousands of people in it, showing absolutely no difference in the survival rates. And I said, this is ridiculous. You know, we should stop. There's no point in going. But they felt they wanted this to be the definitive trial, so they wanted to keep going for another 2 years, I think, with many more thousands. And that's fine. I had actually no problem with that because there's no difference in survival. So I wasn't concerned that people were getting an inferior treatment, because as far as I could tell, they were both the same. So those kinds of discussions go on, but as I said, even if the committee reports to the investigators, they have their interim analysis, now I come back to you and I say, oh, carry on, there's actually information in that to you, because you know there's no big effect that's been seen or no major safety concerns that we have to tell you about. So there is actually a bit of information right there. Yeah. One more question, and then perhaps we should move on. Anyone else have a burning issue? Slightly smouldering? Okay, we've put out all the fires then. All right, good. So we're going to move on then to now on the stepped wedge design, and I just need a moment to get out of this. Yes.